Welcome to the live stage. We're honored to be here. So we want to just start with some preliminary review of the case.
Start with the case review. We have a patient named Peggy. She came to us not too long ago, about a month ago, with the chief complaint of broken tooth number 1, 2. How often do we see this in your everyday practice? A lot. Old crown, broke off, with root canal treated, and then, with the bite, and it comes off. So we want to be able to treat this predictably using implant therapy. Okay. Also, you can look on the bottom of the slide, and you can see several pins on the bottom of the retromolar area. That is due to the surgery that was done in 1990, and due to orthodontic reason and correction of the class 3. Medical history was no significant findings. The range of motion, however, is only 29 millimeter. Whenever we are working with the implant therapy, it's very important to find out how big they can open. Okay, 29 millimeter is not a lot. Okay, and also overjet 2 millimeter and overbite 60%. So overbite is going to be one of the barrier difficulty, because whenever you're doing anterior cases, the deep bite sometimes is more challenging than the shallow bite. Okay, why is that? Because what we're trying to do is take the tooth out, try to place an implant today, and immediately temporize it. Okay, so we have to come up with a prosthetic solution to control that, which Dr. Lu will talk about later on. Okay, whenever we do anterior case, another important thing is smile line. Okay, I jokingly say your first anterior case, do not work on a patient who's a female, high smile line. Okay, so because those are the challenges. There is implant dentistry and there's aesthetic implant dentistry. It's a different level. Front teeth, patients come not for implant, but they come for smile. Would you agree with that, Dr. Lin? Okay, so that puts us at a different challenging level. Okay. Look at over here. Okay, we have an intraoral photograph, and as you can see, is a gum line fracture. So when you have a gum line fracture like that, what's going to be the difficult part? Implant placement or the extraction? Extraction, okay? So I am putting my risk on the stage today. We might have a hard time taking this tooth out, okay? This is as real as it gets. I know many of you come to enjoy the show, but I know many of you come to see Dr. Mark will screw up. So this day might be that day, okay? So congratulations, okay? All right. Next, CT scan, absolutely important, okay? Dr. Marklin, would you agree that now the CBCT is a standard of care?
We're getting to the point, especially on immediate cases.
Absolutely. What are we looking for in a cross-section of a CBCT? Several things. Bone volume, what the length of the root is, remaining bone. So by mapping this out, you have an idea at which angulation, what size, and what length of the implant you're going to use. And also, it's not depicted here, but it will show on the next slide, is the density of the bone. Okay? One of the most underappreciated value in CBCT analysis is the density of the bone. Okay? Medical colleagues call it Hounsfield value. So if you look at the bottom screen, there's a graph. What does that tell you? Along the path of the implant, the bone density changes. So what we're hoping to look for is a Hounsfield value of about 400. What do you see here? A dip down, right down to 134. Is that a good thing or a bad thing? It's a terrible thing. Okay? I chose a case which is not maybe considered to be the most ideal for today. But once again, I wanted to make this as real as possible. Okay? So what does that mean? In the treatment plan, part of it is atraumatic extraction. That's going to be very important, hopefully flapless. And then osteotomy, we're going to use the latest and greatest navigated 3D. So some of you who witnessed today about the Inliant navigation system with Dr. Jimmy Yaginagi, a wonderful presentation. So we're basically continuation of that concept, okay? And then we're going to place a fixture, appropriate fixture. I'm hoping for 3.4 by 15. Okay, why so long? Because I'm looking for immediate stability, okay? And we hope to get above 30 centimeter torque. To me, that's a bare minimum, okay? And then we want to We want to, if we get a chip above 30, we're going to try to go for immediate temporization. If not, we have a backup of removable transitional flipper, okay? So we don't know until we get it. It's one of those situations. But whenever you're doing anterior cases, always have a backup, okay? Always have a backup. Areas of concern, okay? Difficult extraction. Everybody would agree with that. Okay, it's been root canal treated. It's a gum line fracture. Deep overbite, limited interocclusal distance. Okay, that might cause later on with a temporary breakage. And the bone density is below average. So these are the red flag that goes against me. Okay, next one. So we have a carestream intraoral scanning of the top, and from there we are able to assess what angulation of the implant that we want to place. And then we superimpose that, okay, to the navigation unit. It's called a Navident from the ClaroNav. And then we calibrate with the machine, and then we import the STL surface scan with the intraoral scanner. We merge it together, and then we can finally, okay, do the planning in 3 dimensions. And what we've done, actually, we were able to do a virtual surgery even before we go into the patient's mouth. One of the most important things about implant dentistry, especially aesthetic implant dentistry, is planning. If you fail to plan, Dr. Mark Lin will say, okay, you better plan to fail, okay?
The parameters with this case are a few learning points, objectives we're trying to establish. With advances in technology and so on and so forth, we're going to use something called establish profound anesthesia using something called a quick sleeper intraosseous device. It's somewhat new, so we want to introduce this, and there are certain clinical benefits. Obviously, we need to atraumatically, flapless, have that root extracted. I couldn't agree with Dr. Kwan more. Sometimes the extraction takes longer than the implant placement because it's root canal treated, it's dehydrated, it's brittle, and it's below the gum line. So there are certain protocols that we like to utilize, and more importantly, we have to preserve the buccal plate. If not, then we have to be prepared to do guided bone regeneration. Then we like to get that implant osteotomy preparation in precise, exact position based on the planning. And any of you guys who are doing surgery, sometimes on the traditional way of doing it, you have a 2-dimensional x-ray, you do the surgery post-op, you look at it, wasn't kind of what I thought I would aim to do. Well, that kind of guessing game, it's not required anymore. We have a dynamic guided procedure. I'll show you what that means. Live time, you can see exactly the angulation, the position, the depth of the drill, staying away from any vital structures, adjacent roots, nerves, so on and so forth. It will be the standard of care in the very near future. And of course, from the patient's perspective, they feel the reassurance and accuracies of what we're trying to do here. Then, it's very important for us to get primary stability of the implant in any routine protocol, but more importantly for immediate provisionalization. There are criteria we have to meet, at least 30, 35 Newton centimeters, and we want to confirm and check with something called the implant stability quotient. Again, the good old days of reverse torquing is probably outdated. Now we have an objective, tangible number that we can evaluate. Put it this way. At University of Toronto Graf Prosthodontic Clinic, none of my residents are allowed to start the prosthetic phase of implant therapy until we have an ISQ reading documented that we know it's at least 60 or above before we start the prosthetic phase. What else are we going to do with this case? Well, we're going to have a gap between the extraction socket and the diameter of the implant. That gap, lots of studies have shown, Joseph Kahn and other people have looked at, that we don't augment that gap. There's a high incidence rate of what we call buccal ridge resorption pattern. So we will graft the buccal aspect with particulate of allograft xenografts. In a junction, and an additive to that, we're going to use a PRF in the patient's blood that we're going to draw and mix it, and then again enhance the autogenous healing factors within the graft material. If and when the implant gets locked in with what we call primary stability, Dr. Kwan will do what we call immediate provisionalization over this case. And very importantly, we started him talking about why these teeth break. I want to give a rationale for what kind of occlusion that's needed and why do these teeth break. As an aside, my master thesis in 2006 to 2009 was specifically on this topic, single implanted anterior zones. And through my studies, we have found out certain etiological factors that unfortunately make the livelihood of these teeth compromised. It has a lot to do with occlusion, or else things will not snap up the gum line. Okay, so Dr. Kwan is going to prepare the PRF. So when I explain to the patient the various grafting options, you have an allograft, you have xenografts, you have alloplast, and autogenous. Obviously, there are certain clinical benefits to certain the bone material. As a component, if and when possible, we like to have patient's own bone, or in this case, we draw the blood from this. So again, it's a tremendous benefit, and again, coagulating the material, so it's a better handling property. We have enough studies to show there's a tremendous benefit to help the patients heal. So it's an adjunct to what we do for the grafting procedure, and the Bites Institute have courses for this, and whenever we present this to the patients, I've had very little resistance from the patients, because they get it. They understand that the clotting and healing factors can be concentrated. So what I say to the patient is this: I go, Mrs. Jones, you know, when you cut yourself, you know, you got to stop the bleed. There's a clotting factor. Then what happens is the cellular components come with macrophages to digest the bacteria, the contamination, to prevent infection, and or to start the healing process. By using a PRF, what we're trying to do is concentrate all the potentials to help the patients heal, and the patient understands that makes sense. And to have this in conjunction and graft to the procedure is a tremendous benefit. They say it also helps with minimizing discomfort and or swelling to these grafted material when we do guided bone regeneration protocol. So again, when and if the case is indicated, and if you're trained properly, it's a tremendous benefit. So you can look at the Bites Institute. They have courses that will provide all the detailed information. So what Dr. Kwan is going to do is first anesthetize the soft tissues. So there's a double bevel needle that's designed with a quick sleeper. It's proprietary to this needle. It's not the normal ones. So let me say this. I've done this to patients that freak out coming to the dentist. I've done this to dentists and hygienists. And for some reason, with these double bevel design, it does not hurt the patients. You just got to try it on yourself or on a patient. So what he's picking is interradicular bone. He's numbing right now the soft tissues. He's going to go after between the 1-2 and the 1-3 interradicular bone. So he's given the soft tissue infiltration to the soft tissue. You can see it by the blanching of the soft tissues. Now he's going to put the foot pedal, and what's happening is it's a rotary device that slowly and intermittently will drill into the interradicular bone. Once you've penetrated the cortex and you're into the spongiotrabecular bone pattern, he hits another foot pedal, and it slowly dispenses the local anesthetic. Now, I've done this enough to let you know it does take time, and the patients don't feel anything, and time is the critical thing. You remember the rate of injection is proportionate amount of discomfort. So this is regulated and controlled. It does go relatively slow, because you and I as a dentist, they taught you to inject one carpel 1.8 cc should take up to a minute. You and I know we don't take a minute, because a minute standing by the patient is an eternity. So this is a bit slower, so I've learned to, talk to the patients. So this is in lifetime, so I would say, hey, Mrs. Jones, weather is getting nice, this and that. I'm not looking for him or her to respond, I'm just killing time. Distract them so that they're not thinking about what's going on here, and so on and so forth. So we try our best to maintain soft tissue profile. So that means it's a flapless procedure. We try our best to preserve the buccal plate integrity, meaning minimizing the chance of a dehiscence and or fenestration in that area. So what we want to do is try to take the tooth out truly atraumatically. and preserve the hard and soft tissue protocol. So there are different protocols. We can use a chisel, we can use a periotome, and what we're trying to do here is to luxate and widen the periodontal ligament. And the tooth root doesn't have to come out in one or multiple pieces, but again, just to get it out and preserve the buccal plate integrity and the hard and soft tissues. Once you widen the periodontal ligament, you can decide to cut and section the root and extract in multiple pieces. Looks like Dr. Kwan is gonna try to get some beaks and just pops out. Look at that. Good man. Woo! So believe it or not, that is the hard part. So again, getting the root out in one piece. Dr. Kwan is now going to curette, induce a bone bleed. We want to induce a regional oscillatory phenomena where we want the bone to bleed within that socket. Plus, we got to make sure we remove any granulation pathology tissues. Sometimes you think there's nothing there, you got to be aggressive to get this out because you don't want to leave remnant pathological tissues on a fresh implant and so on and so forth. As you can see here, we have the mapping of the osteotomy. We do not follow the apex angulation. As you can see on this design, it's going to be palatal to it and apical to it. For immediate anterior protocols, that's what is mandatory. So you got to make sure the patient's got the available anatomy for that. So now we're going to evaluate and start putting markers in to evaluate. These were the markers we were talking about that we will not need in terms of the extraoral facial fiducial markers. Now with the one scan, the existing scan, if the patient's being referred or already have an existing cone beam, you can utilize that. Before, again, we would have to do another scan, imaging center. We need to image again because we need to have a marker onto that area. So what they're doing now is picking 3 teeth to give an intraoral scenario for the markers to get us prepared for the osteotomy. The objective right now is to correlate what you see in a cone beam to correlate into the intraoral environment. So what we have to do is interpret the data and get that implant osteotomy, again, more palatal and or more apical to engage the bone. So we're just double checking the tags and the traces and the markers right now intraorally. So you can see the guide, you can see the planning has been done, and now they're tracing and mapping, correlating this. So this is very critical. You need to be accurate because these markers of where we're going to rely on for the implant placement. Just like any guide, if you have a traditional lab guide, you got to make sure it's stable in the mouth, it doesn't rock. Just like a guided surgery, you got to make sure it locks in, the soft tissues are compressed, there are no inaccuracies. Because this is the part, to be quite honest, you need to go a little bit slower to get everything accurate, but once this part is done, the remaining osteotomy and the remaining parts of the procedure is quite straightforward. And again, it's, if you will, looking at the monitor and getting a 3D perspective of all the angulations and positions. So Dr. Kwan is now calibrating the drill. Now we're going to be evaluating the positioning of the implant placement with the osteotomies. So as this drill is going in, he's looking at angulation position and he's trying to have this on the bullseye with this scenario. So this is an immediate protocol, so there's no socket, there's a socket in there already. So now this is the challenge. If you haven't done any immediate protocols, you should know and appreciate you got to fight the bone or fight the socket. You're not going to follow down the long axis of the socket. So now he's just repositioning. As you notice, every time he moves, you have all the correlation data all at once provided to you. And the objective is for him to stay within this treatment plan, which we know have the available bone for this immediate protocol. So he's calibrating the drill tip. The tags are being read by the camera. And now we're going to take it to the intraoral environment to evaluate the osteotomy. We can see the shape of the root. Again, we're not going to follow the apex. We're going to be slightly palatal, and we have available anatomy and bone to engage as required into that area. So most of us, when we're doing the surgery, will be looking at this to get kind of the angulation and position. With a healed osteotomy with good bone, it's easier. But now on a socket that's virtually an empty space, that is not as easy to do. So once we start the osteotomy preparation, you will see that we're going to align the angulation and position to follow the planned case. So this is the part where we say, if you play video games, it's a lot easier to do. If you don't play the video games, you got to look at the monitor and try to precisely align yourself with that angulation and position. So again, this concept of mutually protected occlusion is something as dentists you guys have to understand what are the parameters. So again, in the MIP, maximal incuspation position, the patient hits bilaterally, simultaneous equal intensity contacts behind with little to no force in the anterior. And then anterior excursion or lateral excursive movements, you have immediate disclusion of the posterior teeth, either with a canine rise or group function. Those are kind of the general principles of occlusion that you have to make sure you get the patient to harmony. So now we're preparing the osteotomy. We're measuring the angulation depth and position of that pilot osteotomy. We can evaluate with a guide pin, mesial distal buccal lingual, and then palpating is what Dr. Kwan is doing is very critical to palpate the integrity of that palatal plate and making sure where the socket ends, where the pilot osteotomy starts, and again hugging, if you will, the palatal plate into that area. As you can see here, the depth of the implant is critical too. Not so much to the floor of the nose, but getting close to it using the available bone. Also, the cone beam is giving us some information in terms of the quality of the bone, the Hounsfield units. As you can see, the trabecular pattern is very radiolucid. That means that the density or the lack of is a critical component. And this is again something that we have to pay attention to. So I tell the patients, so we're going to go ahead and put the implant in. So the implant is going in and we're looking to lock in with primary stability. So again, we appreciate the lack of density in this bone. Is probably with a Hounsfield of 200 or 300 is probably D4 type of bone. So osteotomy, the preparation is very important to undersize. So we've just engaged the fixture mount. We're getting ready to confirm the implant depth position and also verify the torque value that we need to confirm primary stability. So here we're looking at how deep is the implant, the positioning, because if you don't have it in a restorable position, you don't give yourself enough emergence profile. If it's too shallow, you're going to pay a price. If it's too buccal, you're going to pay a price. So this is a very critical step to evaluate the final restorable position or the final aesthetics. So now, Dr. Kwan has put on something called a multi-peg, specific to this implant diameter and size. And we're going to take what we call an ISQ reading with a penguin. What are we getting? We can't see it in the camera. What are you getting? 66. So on one end is 66. On the palatal, what do we get? 70. So that confirms we locked the implant in with primary stability, or what we also call or term initial fixation. So it's great. We've locked the implant in mechanically. If we didn't get those readings, or 60 and higher, then we would put a cover screw, graft the bone, provide the patient a removable provisional, either an S6 and or a flipper. There will be no immediate loading. So far, we established good profound anesthesia. We've taken out the root atraumatically, preserved the buccal plate. We used the dynamic guided protocol to get the implant very precise to the plan. And now we've locked the implant in. There's a gap junction between the buccal aspect of the implant to the buccal plate. That gap, if you will, we have enough studies to show that that gap on the anterior premaxillary area should be minimum 3 millimeters. We used to think 1.5 is good, 2 maybe optimal. There are again post-insertion studies out there with a robust data to show that buccal to your implant to the buccal plate, we need minimum 3 millimeters of bone. And as such, with good hard and soft tissue biotype, it seems to give us the most predictable long-term prognosis and outcome. So, now we're going to put a temporary plastic PEEK abutment into that area. We usually pre-make a shell of a temporary so that we can intraorally pick it up. So we need to pre-make it. There will be days and times when I can extract the patient's old crown, and my lab will modify that crown to have a lingual or palatal access. Sometimes I've used the patient's own tooth, and this is pre-made by the lab. So to me, what else is better than the patient's old previous crown or tooth? Because it had the natural emergence profile and angulation and position. So now, once we size, this is again a bit of a tricky part, is that you need to know how much to cut and section the temporary PEEK abutment. Then it's got intraoral pickup. Once we do an intraoral pickup, the lab will modify, and you will be able to see that we need to develop the emergence profile of this particular case. So we're using an internal engaged implant system, and Dr. Kwan has beveled the palatal aspect. So again, that's where the screw access hole is going to come out of. And again, we have our choices of using screw retain versus cement retain provisional. Let me say, as a prosthodontist, always go with screw retain, because you want to have that flexibility of retrieving and or taking in and out. A cement protocol is not predictable, and of course usually when the patient's on vacation, the cement comes out, they curse your name and so on and so forth, and the day you want to take it out, you can't get it out, you break the provisional. Trust me, been there, done that. So for all our screw retain, for all our provisionals, it will be screw retained by design. So this is a shell that's been pre-made from the wax setup, and we just line the material over this. So indexes to the rest of the mouth, and we just let the material set. You can remove the excess and or get access to your screw retain scenario. So once the material sets, you can have access to your screw, and once we remove it, the lab will do the rest in terms of finishing the contour of the emergence. Because what you will see is the implant level, obviously the platform and the connection. What you will see is the emergence and or a gap. And the lab can extraorally, without being in the patient's mouth, contour the emergence for that. So why immediates? Well, I can tell you immediates is a tremendous benefit. Number one, the traditional staged approach is you pull the tooth, you graft the bone, you wait 3 to 4 to 5 months, you go through another surgery, you put the implant in, you got to wait another 3 or 4 months before you can go to final prosthetics. So a single tooth in a traditional staged approach, it could take 8, 9, 10, even 12 months before you finally finish. Plus, you have to have multiple surgeries. So patients obviously would appreciate if you don't have to, go through a staged approach. Enough studies also shown that an immediate protocol where you preserve the hard and soft tissue, you have the best chance at holding the mesial distal papilla, the free gingival margin on the buccal, and of course you speed up the appointment down to half the treatment time, about 4 or 5 months. In addition to that, patients love you because you don't have to, again, have multiple surgical procedures. Now, in this particular case, if we can do immediate provisionalization, the patients benefit with that screw retained provisional. So again, they don't have to adapt to S6 and or removable scenario. So again, the post-op instruction is very critical that the patient do not overload this provisional. So soft diet, I personally sometimes will screw the provisional back in, finger tightening it at only 6 to 8 Newton centimeters. I don't torque it in. Why? Because by design, I want the weakest interface between that provisional to the implant. I don't want the patient to load between the implant and the bone. So if the patient comes back after a month or 2 and they say something is loose, I know they haven't been compliant. And I remind them, please know that this is not ready to be fully loaded and don't bite on anything hard. Can you just show that real quick? Can we see the provisional real quick under the camera? Can we zoom in on this? So what we see here is that we have the implant interface very clearly indicated, and now there's a gap between the emergence profile. And now extraorally, the lab can recontour this and smoothen that whole area so it develops the 360 from the platform of the implant through the soft tissues and develop this. So the lab will go ahead and do this. Now Dr. Kwan will put a healing abutment in to hold the soft tissue profile and of course prevent blood getting in and or the graft material. So now we just ask the patient to relax, bite down on the gauze, and it's take the lab a few minutes to do this.
So most of you still here, that means that you're still enjoying the show. If I really screwed up, you'll enjoy even more. Come on, be honest, it's my 6th year, right? Tough case. We deliberately chose a real tough case because I really like to torture myself and excite myself up. PDC. This had all the making of a real life situation where things could not go right. House field value was below 200. I had to under prep it. Like Dr. Lin said, I did that. I had to fight. If you saw the drill drifting a little bit, why was that happening? I was deliberately going against the slide of the path because I want to stay more palatally to engage the higher, denser cortical bone area because I was very desperate to get that initial stability. And I had to go beyond the length to feel for the floor of the nose. Again, why is that? That's where the most dense part of the bone is. And then I used probably one of the longest implant, which is 15 millimeters, okay? And I had to go and grab as much bone as possible near the floor of the nose to get the stability, and I got the stability, and luckily Penguin told me, right? I had about 66
one and then
70 something, okay? Now, by no means it is the best stability, it's not, okay? Because if the patient goes in a crack a crab, next day it could break, okay? These cases, people ask me, aren't you increasing the risk of implant failure by doing this? The most common complication of immediate loading anterior cases is not implant failure. It is temporary breakage. Okay, so they do have to watch out what they eat. I will show you how we modify the S6 stent so that they can wear it nice so that it prevents from touching. We'll do that later on, okay?
Now he's inserted the screw retain provisional. Checking the occlusion, both in MIP, excursive movements, and you do need to reduce the occlusion to make sure there's no contact, zero contacts in terms of an MIP on excursive movements on this crown. So again, this is meant for aesthetics, phonetics. It is not meant for mastication. And the patient needs to be compliant to this. So again, the beauty of this is that it holds the soft tissue profile, and the patient benefits from, there's the shim stock, it's got to pull right through. And ideally, the other canine, or the canine next door, can take the load. The canine can lock in the MIP at 13 microns, but not your implant provisional. Excursive movements, make sure on all excursive movements, the envelope of function, there's no loading onto the crown. So we could use cotton or Teflon tape to protect the screw access hole and to seal the screw access hole. We usually leave this undisturbed for at least 3 to 4 months. And then about 3 to 4 months later, we can get right to the point of unscrewing this, evaluating the emergence profile, and starting our impressions for the final prosthetics, with the benefit of course, developing the other soft tissue profiles. So once the occlusion's been checked, obviously in our own office, we will take a final PA to have a baseline documentation. In about 3 to 4 months, we can unscrew this, take one more ISQ reading to confirm the rate of integration.
Okay, so here's the temporary in, guys. Okay, from a PMMA shell that we milled out from our milling unit, and I took it out of excursion, but I still kept enough of a good aesthetic shape so that patient doesn't have a problem smiling at all. Now this is critical. What you see right here, absolutely critical. Okay. This basically a suck down S6 guard, and then you cut out that tooth. So what happens is at nighttime, that's the most common reason why they break the temporary is a nighttime excursion. By placing it in, nice and snug fit, bite down, they can grind all they want. They will not damage the temporary crown, okay? So they have to wear this every night, okay, until the final prosthetic goes on, okay?
So look, we're all here to learn something. We're all on a learning curve, one way or another. So if you're on a learning curve, we like to let you know, with the Bites Institute, we're here to support you. With my institute, Tide, and if we can help, me and Dr. Kwan, the two marks, we're only an email and phone call away. We'd be happy to look at your cases. We'd be happy to give you guidance, case selection, and so on and so forth. So I want to thank you for your very kind attention, and thank you for Dr. Kwan for this amazing protocol.
Thank you, Dr. Marklin. Thank you.
Thank you. Enjoy the conference. We'll see you around.
Thank you.
Thank you for everything.